Hello, welcome to another session within the modules of African Leadership and Management Training for Impact in Malaria Eradication. I am Ludiko Edward, and I will be with you in today's session that will focus on role of antimalarial drugs in reducing the parasite reservoir. And the learning outcomes for this session is to enable you to understand the role of antimalarial drugs in reducing parasite reservoir, also to understand the rationale behind selection of different antimalarial drugs, which are appropriate to the local situation, and how to design approaches or strategies to achieve the intended objective, whether it is control, elimination, or eradication. And also, we'll be able to describe different strategies where antimalarial drugs are being used. And the outline, you'll have three major components. The first component will be introducing you to antimalarial drugs, which antimalarial drugs are available for use currently. And also what factors you have to consider when selecting antimalarial drugs in reducing reservoir or the parasites. Also, we'll be working around the overview of strategies of parasite reservoir reduction using antimalarial drugs. These include the chemoprophylaxis, mass drug administration, mass screening and treatment, seasonal malaria chemo prevention. And also we're going to now deep dive a little bit into specific antimalarial drugs and what characteristics do they have, and they would fit in what kind of strategy. So let's go. In general, there are several families or groups of antimalarial drugs, and these can be mainly three in terms of the antifolates like sulfadoxine, pyrimethamine, could be the groups of quinolines, which are also subdivided again into aminoquinolines and aryl amino alcohols. The quinines, lumefantrines, they all fall in this group. And also we have the sesquiterpenes, the lactones of sesquiterpenes, like artemisinin and other derivatives of artemisinin. This will be useful when you're looking, when you want to understand how these drugs work and how can they be useful in the malaria control. So the uses of antimalarial drugs can be used in three major areas. This, what you're seeing right now, is a life cycle of the malaria parasites, which involves the component of the mosquito, which is a vector, and then there's a human component. In the human component, there are several stages within the liver, and there are stages within the red blood cells. So antimalarials can be used in prevention of clinical malaria, where once the mosquito bites you, these drugs could go and kill the parasites within the liver or while they're transitioning from the bloodstream to the liver. The second use of antimalarial drugs would be treatment of clinical malaria. Here is another part where you would where the red blood cells are being attacked by the parasite, and this is where the largest biomass of parasites is being produced in the erythrocytic cycle. If you compare this within the extraerythrocytic cycle in the liver, there's a smaller amount of parasites within this section, but the majority of the biomass of the parasites is in the erythrocytic cycle, where you can use to treat clinical malaria. But about 10% of these parasites in the cycle, they convert into gametocytes. And these gametocytes are the ones that are being picked up to continue the infection to the mosquitoes going on. So you could have drugs, antimalarial drugs, that block the transmission, infection transmission to mosquitoes by targeting the gametocytes. These are important things to consider, especially when you're going to be talking about different groups of antimalarial drugs. So the main antimalarial drugs that are currently available for use include the combination therapies, and the artemisinin-based combination therapies are the ones that are mostly available right now and are WHO-approved drugs, including the artemether lumefantrine, where the artemether is the short-acting partner drug that is dealing with the biggest component of the parasite biomass. And there's a lumefantrine component, which, or rather modaquine or mefloquine or piperacin or SP or pyronidine. These are the ones that are much longer acting component to deal with the remaining part of the cycle when the parasite biomass is not completely cleared. And these are usually targeting the clinical malaria treatment. And these are the WHO approved drugs. The artesunate pyronidine, this is a new drug. It is not yet policy for use, but these other ones are approved. Other drugs which are used as monotherapies, which are available, include atovaquone, primaquine, chloroquine, proguanil, and doxycycline. And these can be used in different settings, but not necessarily treatment of clinical malaria, as you will see in the next few slides. So what are the factors for you to consider when selecting anti-malaria drugs for reduction of reservoir? So one would be to consider epidemiological factors. These include the transmission intensity of this area. So places where malaria transmission is high or very high or moderate, the parasite behaves, interacts differently with the human beings compared to in areas where there's low, very low, or there is zero elimination settings. So for example, in areas that have very high transmission, you would expect people to have premonition. The general population will have immunity to malaria, and these would be much older people. So let's say people in age above 5 years. That's why higher population that is at risk is your children under the age of 5, and pregnant women would be much more vulnerable in this section, and they would have they would behave differently. Now, if you try to target the clinical cases only to reduce the parasite biomass in the settings of very high, and moderate, you are going to miss a big part of the population where they are asymptomatic. They have premonition, they have asymptomatic malaria, and they will continue to harbor the infection and transmit. There's a study in Kenya that was done recently, and it showed that almost 28% of the transmissions in high and moderate transmission area was the people responsible for this transmission is the asymptomatic people, these children above the age of 10 and older people. So in this context, you need to consider that in very high or moderate, you have a population of people who will be asymptomatic and might harbor the reservoirs and will continue the transmission. But in a setting of low, very low, even settings where they've reached elimination, majority of the population have not been exposed to the parasites for a long period, more than 3 to 5 years sometimes. And this population is generally vulnerable to the parasites. It doesn't matter whether you're under the age of 5 years or not, which means people will, clinical presentations, people with clinical malaria will definitely, once you treat people with the clinical malaria, you will be more or less reaching your reduction of parasite reservoir. So an epidemiological factor is also very important. An example, this is a map that shows the Plasmodium falciparum parasite rate among children between years of 2 to 10 since 2010, 2002 up to 2019. It's a video, and you could look here, the parasite rate will be changing over time from the year 2000 all the way up. So see, now these areas that are colored blue, these are areas with lower parasite of less than 1%. Areas which are red is almost 100% parasite rate with this group. And you would see the epidemiology is changing over time. The areas with high parasite rate are contracting. Many countries are moving from high to low. Some countries are even attaining elimination with zero transmission. You could see here in Europe, in Americas, but in Africa, they also suggested getting better. So when you want to choose what antimalarials to use in this context, you need to take into consideration the epidemiological factors. Also, another important factor to consider is the prevalent species that are available in that context. So Different malaria species have different activities. So you would see parasite species such as Plasmodium vivax, malariae. They would tend to stay in the liver more as hypnozoites before they get into the circulation. So the type of drug that you use would also depend on the prevalent species that are there. If you use a drug that does not target the liver stages, in a situation the parasites are more targeting the liver stages, you will not be able to achieve your targeted goal. So another factor is the biological factors. And the biological factors, you should consider the host factors, which is the human being, the parasite factor, which is the Plasmodium falciparum itself, and the biology of the vector. So we're looking at different factors that affect this selection of your choice. So when you look at host factors, human beings get bitten differently, more like malaria harboring mosquitoes bite humans with specific preference. So people who have lower body mass, people who have excretion of more carbon dioxide and odor in their bodies, specific body odors, pregnant women, and people with smelly feet, for example, the mosquitoes tend to bite them more. So would you want, when you're doing an intervention and selecting the drugs for this different population, you take into consideration the group that you're targeting in that context. The second thing you could look into these biological factors in the parasite component is the duration of the gametocytemia, for example, if your target is to reduce transmission. So different species of Plasmodium have a different duration of, or when do they form the gametocytes since the infection is established. So Plasmodium falciparum, for example, the conversion from asexual to sexual stages to gametocytes happens later. It takes up to 10 days after the infection establishment and the sexual cycle, they get to be converted into gametocytes. So if you're going to give gametocytemic drugs, which are transmission blocker, in clinically ill patients in Plasmodium falciparum setting, then you're going to miss the gametocytes. While if you look at other species which tend to form gametocytes concurrently, this is an important thing to also consider. Another thing is infectivity of the gametocytes to the local vectors. And this is important to consider because the amount of gametocytes needed to establish an infection in a mosquito is very low. We're talking about you need only one male gametocyte and one female gametocyte to get into the mosquito to be able to establish an infection. And in this context, what ends up happening is if you're going to treat the people who have gametocytes and you use tools to measure gametocytemia, such as microscopy or rapid blood tests, there are limitations to the amount of density that these tools can detect. So with the parasite density of 3 parasites per microliter of gametocytes, you can establish an infection. But a microscope can have a limitation of detecting up to 10 gametocytes per microliter. Then this means you're going to, if you select only people who test positive, then you're going to miss the opportunity to treat the people in the population. We'll see this one also in some case studies later. Also, again, abundance of and behaviors of local vectors. This is another important thing to take into consideration. The mosquitoes themselves, there are some drugs that when given, they would also get to act inside the mosquitoes and prevent the sexual replication in the mosquito. So this is another important thing to take into consideration. So there's a pharmacological consideration also for you to take into account, pharmacokinetic and pharmacodynamics of different drugs. And there are drugs that are cleared much faster in the system than other drugs. And when you're trying to decide whether or not you want long-acting drugs or short-acting drugs, this is a very important consideration. There are drugs whose half-life is only 2 to 3 days or a few hours. There are other drugs which are much longer acting, which would stay in the blood much longer, which means would prevent the establishment of an infection for people who are exposed in a much longer context. So also, you should consider action of drugs in species specific stages, right? So there are drugs such as the artemisinin, which would act on a sexual stage and also would act in early stages of the gametocytes. So if you choose this drug, you are going to kill the early stages of the gametocytes and sexual stages. But there are other drugs that cannot target places like the gametocytes or the hypnozoites or the asexual stages in the blood circulation. Another important component to look into when you're as a pharmacological consideration is the antimalarial capacity in reducing the drug dermatocytemia or even just parasitemia in general. This is the drug resistance issue where different drugs have started to develop resistance. We've seen this in chloroquine and sulfadoxine pyrimethamine SP, and also now we're seeing cases of resistance to artemisinin based combination therapy. So this is another very important consideration when you're trying to decide what drug to use. Great. Now we're going to talk about the overview, give you an overview of different strategies that could be used when it comes to parasite reservoir reduction. Here we can see two. One is prophylaxis. So prophylaxis can be in terms of causal prophylaxis or suppressive prophylaxis. I'll explain this a little bit. So causal prophylaxis are the ones that happen in this part of the establishment stage. So this is where causal prophylaxis happens. You prevent causation of the clinical disease. But also suppressive prophylaxis is when you wait until the establishment of the infection has happened in the liver, and you suppress the erythrocytic cycle of the infection. So this is an important thing to take into account, because we have drugs like atovaquone plus proguanil as a combination, which is also known as Malaron, and primaquine. These are given also to travelers who come or go to countries that are malaria endemic, and they would prevent the people from getting infection. And this means that once a person leaves the endemic country, can stop taking the medication. While suppressive chemoprophylaxis drugs like chloroquine, proguanil, mefloquine, doxycycline, these are drugs that need to be used at least 10 days before and continue use up to 14 days after someone has left the endemic country, to make sure that if the parasites were in the liver, they don't get into the circulation. Another component is the intermittent preventive or presumptive treatment in high-risk groups. So these are groups like the pregnant people, where you would be able to treat them whether or not they show symptoms. So in pregnancy, for example, the sulfadoxine pyrimethamine is used to give into pregnant women. At least 3 complete doses is what's targeted, and every time a woman comes to visit a clinical setting would get this dose to prevent this. And there is evidence that has shown that intermittent presumptive treatment in pregnancy reduces pregnancy-related complications and increases maternal-related outcomes. But it's worth of note that sulfadoxine pyrimethamine resistance is one of the issues that are of concern in this context as a factor of consideration. In West Africa, the prevalence of the resistance to SP is not as high as some parts of East Africa, but for now, the guideline is to still use SP for that. And the same sulfadoxine pyrimethamine is used for intermittent presumptive treatment in infants when they are in their first year of receiving immunization. They're also given these doses of SP, at least 3 complete doses of sulfadoxine pyrimethamine. So these are policy-wise and are also already recommended and are also put in action. But in the context of school-age children, this is another high-risk group. Research is still ongoing with regards to whether or not school-age children can be treated with ACTs, atomicin-based combination therapies, as part of presumptive treatment to reduce parasite burden. So in this context of, these are 2 strategies here, prophylaxis and intermittent presumptive treatment. And another strategy is mass drug administration. This is treatment of all people or a section of population, whether or not they are symptomatic. And this is great when you're looking at controlling epidemics. And also it's great when you want to reduce or interrupt transmission. And it's quite useful when you're looking at elimination initiatives, because you would generally try to treat everyone within the population, and could be used as a measure to control multi-drug resistance. However, there's a risk again of causing drug resistance depending on which medication are you using for this mass drug administration. We go back to the pharmacological consideration of the drugs, and it also, WHO recommends this in complex emergencies where health systems are overwhelmed. You could just take everyone and do mass drug administration. In cases where in West Africa, where there was an Ebola outbreak and people needed to use the healthcare system for Ebola cases, and to prevent an increase in cases of malaria, they used mass drug administration. So this is one of the strategies that could be used. Another strategy is mass screening and treatment. So this is different with mass drug administration in terms of all people in the broad geographical areas are screened regardless of whether they have symptoms of malaria, and the ones that are positive get to be treated. This is very useful because it also provides data on epidemiology of malaria once you do it in a big setting, and it's much more focused on the people that get positive. But also it is resource intensive in terms of being able to treat and test and treat everyone within the population. So it's quite an important consideration to make in whether you have resources available. And there's also limited insensitivity of the diagnostic tools. So this is when we were talking about whether you're using microscopy, or you're using molecular tools, or you're using lateral flow immunofluorescent tools like rapid diagnostic tests. These tools have limited sensitivity depending on where you use them. If you have parasite density of more than 10 parasites per microliter, then you might be able to use the microscopy. But tools like loop-mediated thermal amplification LAMP will be a useful tool to take into consideration, which are much more sensitivity. But then these molecular tools are complex at times, and like PCRs, you can't do them routinely in a programmatic level. So this is an important thing to take into consideration when you want to do a mass screening and treatment as part of the reduction of parasite reservoir. This is a case of Zanzibar, where this publication was done in 2014, but it was looking at mass screening and treatment as a basis of results of Plasmodium reduction, and they were not able to demonstrate any reduction in malaria incidence in Zanzibar. So this one, in this case, they measured a population of 64% of the population that was screened, and the prevalence that was measured using rapid diagnostic tools was 0.2%. And my reason of bringing these studies here is to show the difference, how you could miss people in mass screening and treatment because of the limitations of the diagnostic tools. So rapid diagnostic tests were able to detect only 0.2% when you compare they did 2 rounds of mass drug administration. When they use PCR to measure the prevalence, they got up to 2.5% and 3.8% of the people were still positive. So you could see rapid diagnostic tests could not detect more than 2% of the parasites, or actually even 3% of the parasites, people within these areas. So this limitation of diagnostic tools can be demonstrated as such. And another alternative would be now to do focal screening and treatment, where you screen everyone and treat them, but then for all within the people who test positive in a defined geographical area. This is another example in Zanzibar that would, in many other places, that would take a person who comes to the hospital and tests positive, and then they would go to their home and then measure whether other people in the family have malaria and treat the family members to make sure that they are also rid of the parasite reservoirs. And this is operationally more feasible than mass screening and testing, but it doesn't deliver in a whole area that sustains malaria transmission. This is another factor that it's important to consider. In areas where there is very low transmission, there are pockets of high transmission, and these pockets are far apart sometimes. And the more you look into granular details geographically, you will see the hot areas where there really malaria is ongoing in that particular area, which is maybe within a span of 2, 3, 4 kilometers squared than other places. So it might not, this focal screening and treatment might not be suitable for elimination efforts, because you might be missing these other hotspots that are of transmission. So this is another study by Anders Björkman, which again, as a case of Zanzibar, to show how spatial distribution of malaria infection in Zanzibar and the implication of focal drug administration strategies for asymptomatic carriers. And the reason I wanted to show you here this study is because they looked at people who were positive in their homes, and then they did a perimeter survey to see the people around that area also, how far and wide could they still get positive people. So in this context, they found that the odds ratio of being PCR positive was 7.4 times for those people who live in the household of someone who's positive. And for people who live within 300 meters, it's the odds 1.6. Compared to the people who live more than 1,000 meters, like, or kilometer away. So treating everyone within the household would be useful, but you only target 1% of the population. But if you take wider, let's say people living within 300 meters, you are going to get at least 14% or 15% of the population within the RDT tested, but that's more than 60% of the people that would be PCR positive. So widening the focal drug administration is also useful. This is even more evidence for us to see how the focal drug administration might not be very useful in an elimination setting. And the final tool is the seasonal malaria chemoprevention. This is community-based intermittent administration of the full course of anti-malaria medicine within malaria transmission season. And this means you have to plan at least a few months, 5-4 months before and the transmission starts. And this is a prevention strategy for children under the age of 3 months to 59 months. And the most significant case is the 13 countries of the Sahel region in West Africa, where they were targeting about 22 million children to treat them before the transmission season happens. This means when the malaria transmitting vectors come and bite these people, they will already have the medication in their bodies, and this infection will not be established, or the parasite reservoir has been also dealt with. So this is a video that will show an example. It's a 5 minutes video to show you an example of seasonal malaria prevention in the Sahel region.
Malaria kills about 1.1 million people every year, most of them children in sub-Saharan Africa. Now, an old method to prevent the disease is making a comeback. Children in Mali, Senegal, and other African countries are swallowing malaria pills throughout the rainy season when malaria normally peaks. For decades, public health experts warned against just this strategy, known as chemoprevention, because it will cause widespread drug resistance. But the alternative, a massive number of deaths every year, seems worse. I wanted to know how African mothers, scientists, and health workers felt about the intervention. So I traveled to Mali to talk with them and to watch how the pills are distributed to thousands of kids during the rainy season. On the day before the rollout, small groups of health workers congregate for training sessions. They receive a backpack with anti-malaria pills and tools to dissolve the pills in water. Here, the medical supervisor explains that these pills are for healthy children. They want to save the gold standard malaria medication for when the children fall sick. On the day of the rollout, mothers and children arrive by foot and by donkey cart from the farms where they work. They gather outside of a one-room schoolhouse, today a temporary clinic. Inside, the health workers mash up the pills, plop them in water, and hand the bitter yellow liquid to children to swallow. It's September, and children in this village have been taking the pills once every month since the rainy season began in July. Normally at this time, children suffering from malaria will fill hospitals. But with chemoprevention, most children remain healthy and their moms don't need to worry. Throughout the day, community health workers repeat a mantra, better to prevent than to treat.
Women like malaria prevention for their kids because they benefit so much from it. That's what he said. Because in addition of saving money, because they won't have to take them to the hospital, they also have much time to take care of their field, the farm work, and not attending their sick child at home.
Last year, the World Health Organization recommended chemoprevention for countries like Mali, Senegal, and Nigeria, places where malaria mainly strikes during the rainy season. The intervention has been a decade in the making because health officials were concerned about side effects and about the risk of resistance. Those fears are actually justifiable, but over the past decade, scientists have shown that the treatment reduces malaria cases by more than 80%. The benefits outweigh the costs, says Badara Cisse, who helped run the largest trial in Senegal.
I don't think that it will be appropriate to not give these drugs to those who need them because of potential resistance. We have to use them, and at the same time, we have to monitor continuously.
To keep tabs on resistance, researchers will analyze spots of blood collected from malaria patients to see if the parasites have evolved mutations to overcome the therapy. One of these researchers, Alassane Dicko, is thrilled to see the intervention take off.
Compared to the current tool that we have for malaria control, it's really ranked very high. And when you have BetNet and when you have other interventions. So we believe that what we really needed now is to implement this very quickly.
The science behind chemoprevention is simple, and in studies, it's clearly powerful. Now, the main obstacle is what some people in the aid world call the last mile challenge. It's logistical hurdles. It's why polio has been so hard to eliminate, even though the vaccine has been around for decades.
I'm really optimistic that we can make it, in fact. But we need a strong commitment of our medical authorities. And maybe that's what we lack most.
There are 25 million children who stand to gain from chemoprevention if only health workers can reach them.
So, hope you gathered a few as insights from that case study. And now, to finalize, we're going to talk about the characteristics of these drugs. And you've seen they're talking about the drugs that are used for that. What kind of drugs could be used in what kind of setting? So we'll start with the artemether-lumefantrine, which is, you have to consider the following things, the selection of the criteria. You have to consider whether or not the drugs are efficacious. You have to consider the half-life, the safety, administration, whether it's available, presentation, and also if the drug is commercially available in pre-qualified formats, right? So in most settings, artemether-lumefantrine is efficacious and has a duration half-life of about 11 days, the lumefantrine component, which is longer acting. And this drug is generally safe and well tolerated, and it's given twice daily for 3 days. And it's recommended to give with fatty foods. And this is now brings the logistical challenge of whether or not you could give artemether-lumefantrine in a mass drug administration with the logistical consideration of the food. Also, it's available in fixed dose combination, and it is widely available commercially. Drugs like artesunate amodiaquine, which is efficacy is variable because of an emerging resistance to amodiaquine specifically, but it has a slightly longer duration of half-life between 3 days to 10 days, and it's generally well tolerated, but there is evidence of amodiaquine prolonging the QT interval in the heart. So people with cardiac issues such as prolongation of QT, or people who use other medication that use a prolonged QT interval in the heart should be considered. So this is something you need to take into account, especially when you're designing an intervention in places where drugs like efavirenz or zidovudin, or cotrimoxazole, which are for HIV patients, are given. So whether or not you're going to eliminate this population or give them a different medication, that's important. But this one is given once daily for 3 days, and there's no requirement of food, which is better than lumefantrine logistically, if you think about it. And the fixed dose combinations are available. Fixed dose combination is like one single tablet with a combination of drugs. And also it's widely available and pre-qualified, WHO pre-qualified original and products. And there are also generic products that are provided. Another one would be artesunate mefloquine. This is the efficacy is high in most settings, and it has slightly higher half-life in terms of 50 up to 15 days, from 8 to 15 days. So you might want to consider whether or not this is a drug you want to use, especially in conditions like seasonal malaria prevention, where you want to protect them for say a longer time, every other month. And this is where people which are given monthly treatment for these drugs are well tolerated. For example, in places where you do SMCs. And administration is generally once daily for 3 days, and fixed dose combination is available for these drugs. And drugs like artesunate sulfadoxine pyrimethamine, which has a problem of widespread resistance of SP, but has a much longer half-life of the drug, which is why is preferred to be used in pregnant women and also in infants for use. And but must be used in patients if you have sulfur hypersensitivity, or use other sulfur-based drugs like Septrin or cotrimoxazole. You should be careful not to give these people this drug. Another component is this one is used once daily for 3 days, but then unfortunately there's no fixed dose combination available. So you have to give blister packs of artesunate and another blister pack of sulfadoxine pyrimethamine as a monotherapy. The single pre-qualified product is limited in production capacity. And finally, we have the dihydroartemisinin piperacin, which has high efficacy in most settings, and has quite long half-life of up to 28 days, which is also a preferable drug for much longer treatment. But then there's an issue of QT interval prolongation, which needs to be considered in safety. And it's a once daily dose for 3 days, and preferably on an empty stomach, maybe 3 hours before meals, which is very not likely to be feasible during a mass drug administration, because you just go and give people whenever. You don't have to tell them they should be fasting or something like that. So that's another thing to consider. Fixed dose combinations are available, and pre-qualified products, there's a limited production capacity. So once you look at all these factors, then you can decide, oh, okay, given my setting, given what I want to target, whether it's control, given my setting, which drug will be useful. Great. So generally, we've spoken about antimalarial drugs, and these we know for sure they have a significant role to play in reducing parasite reservoir in man. Strategies such as mass drug administration, screening, mass screening and testing, focal screening and testing, seasonal malaria prevention, chemoprophylaxis can be used, but need to be carefully planned. And planning needs to take into account biological, epidemiological, and pharmacological factors for efficacious use of antimalarial drugs. So these are the references that we've used, and I hope you will go and read more on this and get more acquainted with the material that I've shared with you. I've just given you a skeleton of what you need to know, but I'll be responsible to get the meat out of it. Thank you very much.